Hello everyone, welcome to another lecture of Mediculture. In today's lecture, we are going to discuss some high yield questions and PYQs related to vesiculobullous lesions. This topic we covered in detail in the previous lecture, so let's start with the questions. The first question that can come is that the row of tombstone appearance can be seen in. So the answer is pemphigus vulgaris. Remember, in previous lecture we discussed the row of tombstone appearance. So, answer is pemphigus vulgaris. Next, acantholysis is a characteristic of. Again, the answer is pemphigus vulgaris. Next question. Autoantibodies in pemphigus vulgaris are directed against. So, the answer here is desmoglein 3, or in some cases 3 plus desmoglein 1. If only desmoglein 1 is involved, it is the indicative of pemphigus foliaceus. So remember, desmoglein 1, pemphigus foliaceus. Nikolsky sign is positive in. The answer here again is pemphigus vulgaris. Where else the Nikolsky sign is positive? So it is positive in pemphigus vulgaris, number 1. Second, in toxic epidermal necrolysis. Then, and third, in staphylococcal scalded skin syndrome. Skin syndrome. So remember this. Nikolsky sign is positive in pemphigus vulgaris, toxic epidermal necrolysis, and staphylococcal scalded skin infection. Next, clefting level in pemphigus vulgaris is, yes, do you remember the clefting table we discussed? So in pemphigus vulgaris it is suprabasilar or intraepithelial cleft. So the correct answer here is suprabasilar. Sixth question. Characteristic of immunofluorescence pattern in pemphigus vulgaris. So the answer here is that the immunofluorescence pattern, it gives a fishnet appearance or a chicken wire appearance. So remember immunofluorescence pattern in pemphigus vulgaris. Next question. Oral lesions are the first manifestation in. Again, here the answer is pemphigus vulgaris. Let's recall the comparison table. Remember that the oral lesions, they are seen in pemphigus vulgaris and mucous membrane pemphigoid. However, they are the first sign or the first appearance. It occurs in pemphigus vulgaris, and in mucous membrane pemphigoid they are common. However, they are not the first manifestation. Next question. Flaccid bulla, or the bullas or vesicles which can rupture easily, they are seen in. Again, the answer is pemphigus vulgaris. 9. Desquamative gingivitis is commonly associated with. It is associated with pemphigoid group. Pemphigoid. Bullous pemphigoid is characterized by, let's come back to the clefting tables. Now, bullous pemphigoid shows subepithelial cleft. So, subepithelial cleft or clefting at basement membrane zone. Now, a question can come that which exact level in the basement membrane or above the basement membrane the clefting is involved. So, clefting occurs at the level of lamina lucida. Remember two layers of basement membrane, lamina lucida and lamina densa, right? Ludae. So, at the lamina lucida level, and it is also called as dermoepidermal junction. Dermoepidermal junction. So the answer is subepithelial cleft or clefting at basement membrane zone or lamina lucida or dermoepidermal junction. Now, autoantibodies in bullous pemphigoid they are directed against hemidesmosomes. Now, which exact hemidesmosomes or what are the target antigens? So, what are the exact target antigens in hemidesmosomes? These are PP180 or BPA-G2 and second BP230 or BPA-G1. So remember the exact target antigens in bullous pemphigoid. Next, linear immunofluorescence at the basement membrane is seen in. It is seen in bullous pemphigoid. Now, what did pemphigus vulgaris show in immunofluorescence pattern? It showed a fishnet or a chicken wire appearance. And bullous pemphigoid, it shows linear appearance. Next question. Iris lesion is a characteristic of erythema multiforme. This question was a PYQ which was asked in NEET exam. Erythema multiforme. So see, these are the iris lesions. The target iris lesions. And it can involve palate and lip. Next, severe form of Stevenson-Johnson syndrome is toxic epidermal necrosis. Cystin. Most common trigger factor of erythema multiforme. It is herpes simplex virus. We did this in the previous lecture or the previous video. So if you want to revise, just go through the old lecture. Next question. Ballooning degeneration. It is seen in, again, herpes simplex virus. Multinucleated giant cells are seen in, again, herpes simplex virus. Next question. Dermatitis herpetiformis is associated with gluten sensitive enteropathy, gluten sensitive enteropathy, or celiac disease. Next question. Immunoglobulin deposited in dermatitis herpetiformis is IgA. Again, an important question. Which Ig is deposited in dermatitis herpetiformis? It is IgA. Next question. Genetic vesiculobullous disorder. Let's go back to the classification. So, genetic vesiculobullous disorder, it is epidermolysis bullosa. Epidermolysis bullosa. Next question. Involvement of both oral cavity and conjunctiva. It is seen in mucous membrane pemphigoid. Mucous membrane pemphigoid or cicatricial pemphigoid. Another name was cicatricial pemphigoid. Now a question can come here is that which ocular manifestations or complications they are seeing. So the first one is symblepharon. What happens here is that the eyeball and the inside of the eyelid, it gets stuck. So adhesion between eyeball and inner eyelid or inside of the eyelid. Side of eyelid. Second complication that can be seen is ankyloblepharon. Chyloblepharon. What happens here is that the upper and the lower eyelid, they get stuck together or adhesion occurs between upper and the lower eyelid. The third complication, it is blindness. Adhesion between upper and lower eyelid and blindness. So symblepharon, ankyloblepharon and blindness. These are the three complications or the ocular complications involved in mucous membrane pemphigoid. Now let's discuss some cases. A 45-year-old female presents with painful ulcers and ruptured blisters involving buccal mucosa. On slight pressure adjustment, normal mucosa peels away. Histopatch shows suprabasal clefting and acantholysis diagnosis. So this sign, it is the Nikolsky sign, and suprabasal cleft and acantholysis, they are characteristic of pemphigus vulgaris. Vulgaris. So I would like to discuss one point here. Do you remember the Znag cells or the free floating or the acantholytic cells? We know they are seen in pemphigus vulgaris, right? They are also seen in herpes simplex virus, in varicella virus, and in some cases bullous pemphigoid as well. Bullous pemphigoid. So remember, the Znag cells, they are seen in pemphigus vulgaris, herpes simplex virus, varicella zoster, and bullous pemphigoid. Next question. A 68-year-old patient presents with large tense bulla, which means it doesn't rupture easily. Oral involvement is minimal. Histology shows subepithelial clefting. So, what's your diagnosis here? The answer is bullous pemphigoid. Why not mucous membrane? Because mucous membrane would show both oral and ocular complications. Next question. A middle aged woman presents with desquamative gingivitis. We know it is a pemphigoid and painful erosions. Histology shows subepithelial clefting. So the answer is mucous membrane pemphigoid. Desquamative gingivitis, it is a characteristic of mucous membrane pemphigoid. Next, a patient develops acute painful oral ulceration and target lesions on hands after herpes simplex infection. So, after HSV is a trigger factor or a stimulating factor of erythema multiforme, just like we discussed in the previous lecture. Next question. A young adult presents with multiple painful vesicles on lips and oral mucosa. Znack smear reveals multinucleated giant cells and ballooning degeneration. These both are the features of herpes simplex virus, just like we discussed above. Ballooning degeneration and multinucleated giant cells are feature of herpes simplex virus. Next question. A patient complains of intensely pruritic vesicles on the extensor surfaces. Intestinal biopsy reveals gluten sensitivity, enteropathy. So, which vesiculobullous lesion is associated with gluten sensitivity? It is dermatitis herpetiformis. Next question. A child develops recurrent blister formation following minor trauma since birth. Since birth means it is genetic. So the answer is epidermolysis bullosa. It is genetic. Only one vesiculobullous lesion falls under the genetic category. So epidermolysis bullosa. Next, a patient presents with superficial fragile bulla affecting skin. So it ruptures easily. Histology shows subcorneal clefting. Where subcorneal clefting is seen, it is seen in pemphigus foliaceus. Refer to the clefting table. Pemphigus foliaceus, so subcorneal cleft. A patient with vesiculobullous lesions show peeling of superficial epithelium when lateral pressure is applied. Now, which sign is this? It is Nikolsky sign. Next question. A woman presents with erythematous peeling gingiva that bleeds easily. So, which condition? It is desquamative gingivitis. Gingivitis and associated disease is mucous membrane pemphigoid. Mucous membrane pemphigoid. Remember that there are a lot of lesions associated with desquamative gingivitis, but your first option should be mucous membrane pemphigoid. Okay. Next question. Ulcers on palate, fever, and lip infestation. Drug history of ibuprofen. The patient is suffering from. Now, remember in the classification, we did the triggering factors of Stevenson Johnson syndrome as NSAIDs, non-steroidal anti-inflammatory drugs. So, it is a direct question for Stevenson Johnson syndrome. So, remember all the triggering factors or the uh, stimulus which precipitates the hypersensitivity reaction. It's not important that they are going to ask only the major one, right? They can ask any of the given, either anti-epileptic, antibiotics, or NSAIDs as well. Same for erythema multiforme. So in recent years, the exam has basically there has been a shift in orientation of exam towards more clinical aspect. So it is must that we discuss the medicinal, the treatment part of these lesions. So for pemphigus vulgaris, the medications or the treatment, it is systemic corticosteroids. This has been a PYQ, and the drug of choice here is prednisolone. Prednisolone, and sometimes rituximab, which is a monoclonal antibody. So remember this as well. Now, for mucous membrane pemphigoid, it is topical plus systemic corticosteroids, and for bullous pemphigoid, it is corticosteroids, again both systemic and topical, plus dapsone. Depends upon case, varies case to case. Now, for erythema multiforme, we all know it is a hypersensitivity or immune mediated type. So, the first step here is to stop the offending drug or the stimulating drug. Now, in case it is caused by HSV, treatment of herpes simplex virus, which is acyclovir, antiviral drug, prophylaxis. Next question. Varicella zoster, again viral infection, so an antiviral drug is used here, acyclovir plus pain control, so NSAIDs basically. Now last is dermatitis herpetiformis. Again here dapsone is indicated, or it is the drug of choice, plus gluten free diet since it is associated with celiac disease. Now, dapsone, it is a sulfone class of antibiotics. So, remember the treatments of the vesiculobullous lesions and how they vary. For the viral group, of course, we'll use antiviral drug, and for the autoimmune, we would use monoclonal antibody and corticosteroids. In dapsone, it is indicated for bullous pemphigoid and dermatitis herpetiformis. Okay. Now there are few other important questions. Number one here is primary herpetic gingival It is commonly caused by. It has been commonly asked in sample papers, this question. So the answer is herpes simplex virus type 1. Remember the type. It is the type 1. Now, herpengia. We discussed herpengia in sorry. We discussed herpengia in the viral group itself, right? Under the infectious type. So, herpengia, it is caused by Coxsackie virus. Coxsackie virus. Type A. Now, what is herpengia? It's basically a viral infection which presents as high fever, and shows small grayish white blisters with red border. So basically a red border with grayish white blisters. Now, lesions, they occur on soft palate, tonsillar pillar, and uvula. Remember that this pathology, it spares interior region of the mouth. It does not affect interior region, and it is self-limiting. It resolves in 7 days or within 7 to 10 days. This was about herpengia. So it presents with high fever, small grayish white blisters with red border. It affects soft palate, tonsillar pillar, and uvula, and it spares interior region. Resolves in 7 to 10 days. And it is caused by Coxsackie virus type A. Okay, so this was about herpengia. Now, next question. Hand, foot, mouth disease. It is caused by, again, Coxsackie virus, but this type here is A16. So remember, A16 type. Next, Cowdry type A inclusion bodies, they are seen in. Now we will discuss the different elements or the inclusion bodies that are visible within cells in certain pathologies. But let's for now remember that Cowdry type A inclusion bodies, they are seen in herpes simplex, and varicella zoster virus. We will discuss about them in detail later. Just remember they are seen in herpes simplex and varicella zoster. Now, Ramsay Hunt syndrome, it is caused by, so it can either be caused by varicella zoster, varicella zoster virus, plus involvement of the cranial nerve 7, which is the facial nerve, in geniculate ganglion. We will discuss about this syndrome later as well in detail. Just remember for now that it occurs by activation or infection of varicella zoster virus, or sometimes involvement of facial nerve in the geniculate ganglion. Now, we discussed the immunofluorescence pattern of pemphigus vulgaris above. It was fishnet or chicken wire pattern, right? Chicken wire appearance or pattern. In bullous pemphigoid, it shows linear pattern or linear immunofluorescence pattern. In dermatitis herpetiformis, remember there is a deposition of IgA in this pathology. So here granular IgA at tips of dermal papilla, it is seen. Remember this, granular IgA at tips of dermal papilla. Now, what is paraneoplastic syndrome associated with? Just remember that this syndrome, it is associated with Castleman disease. No need to go in detail, just remember these points. Or non-Hodgkin lymphoma. So Castleman disease or non-Hodgkin lymphoma. What is linear IgA dermatosis? First of all, it is common in children. And it gives a string of pearls or cluster of jewel sign. Cluster of jewel sign. Just remember the appearance of the histopath section. String of pearls or cluster of jewel sign. Now, what is salt split skin? So it is basically a diagnostic test which is done for vesiculobullous lesions. For vesiculobullous lesions, to elevate, this is done for vesiculobullous lesions to evaluate subepidermal binding. Evaluate subepidermal binding. So it can be asked, it is an important question, what is salt split skin? It is basically a diagnostic test for vesiculobullous lesion to specifically evaluate the epidermal binding status. Epidermal binding. Now here what happens is that the immunoglobulins, uh, their foundation, they are checked where the adhesion occurs. So remember that IgG in this test, under this test, it binds to roof in epidermolysis bullosa acquisita, and it binds to floor in bullous systemic lupus erythematosus, which is lupus disease. It's a type of bullous vesicle formation. So remember that IgG binds to roof in EBA and to floor in bullous SLA. Okay. Now the last topic we have to discuss are the hypersensitivity reactions. So we all know there are four types of major hypersensitivity reaction, which is type 1, type 2, type 3 and type 4. So let's start. Remember that no vesiculobullous lesion show type 1 hypersensitivity reaction. No vesiculobullous lesion shows type 1 reaction. Here basically involvement of IgE occurs, right? Except some cases of bullous pemphigoid. Bullous pemphigoid. So in options, if bullous pemphigoid is not given, you can take that no lesion, no vesiculobullous lesion. It shows type 1 reaction. And not every bullous pemphigoid patient would show type 1 reaction, only in some cases. And which drug is indicated here? Here it is, omalizumab, which is basically an anti-IgE drug to lower the hypersensitivity reaction. Okay. Now, type 2 hypersensitivity reaction. Type 2 hypersensitivity reaction. What happens here is that there is a formation of antibody. It's a formation of antibody against a cell surface or structural antigen. So, antibody formation against a cell or an antigen. Which lesions show this type of reaction? It is the pemphigus group, the pemphigoid group, and epidermolysis bullosa acquisita, which comes under autoimmune type. So basically, all of these are actually all of these actually comes under the autoimmune group. So if a question comes that bullous pemphigoid show type 1, type 2, type 3 or none of the above hypersensitivity reaction, Your answer should be type 2 because pemphigoid group is involved. However, if type 1 is involved, hence you can tick type 1 as some cases of bullous pemphigoid they show type 1 of hypersensitivity reaction. And remember that EBA, not EB, it shows type 2, the autoimmune group. Next is type 3 reaction. What happens here is there is a formation of immune complex. And which lesions, which pathology come under this? It is um, this dermatitis herpetiformis. Remember which immunoglobulin is deposited in dermatitis herpetiformis? It was IgA. So IgA immune deposits occur here and immune complex is formed. So type 3 reaction. And last one is type 4 hypersensitivity reaction. What happens here is that there is an involvement of cytotoxic T cells. Cytotoxic T cells. So basically killing of the cells occur by cytotoxic T cells. And which lesions, which pathology come under here? It is erythema multiforme, lichen planus, and contact or amalgam lichenoid reactions. So remember erythema multiforme, lichen planus, and amalgam lichenoid reactions. They come under type 4 hypersensitivity reaction. Now, another important question that can come here is that we know that EBA falls under the type 2 reaction, right? Now they can ask that EB, epidermolysis bullosa, falls under which hypersensitivity reaction? So remember that EB was, just recall it comes under genetic group or it is inherited. Okay. So it is not an autoimmune disease, it is not an hypersensitivity disease. It is an genetic or inherited disease. So it does not fall under any hypersensitivity reaction. So none of above, since obviously it is genetic in nature. So that's all for today. Thank you for watching.